Okay, ladies and gentlemen, once again, welcome to the 46th Annual Conference of the Kerala State Chapter of the Association of Surgeons of India, being hosted by the Kottayam Surgical Society. And this year's conference will be held under the theme of Advancing Surgery and Advancing Lives. We just start in a couple of minutes. May I request you to put your phones on silent or on vibratory mode, please. The organizing secretary, Dr. Bibin P. Matthew, will be on in a couple of minutes to make the opening remarks. We have the much awaited quiz, which will be anchored by Dr. Arunkumar, Senior Consultant, SGE Hospitals, Thiruvananthapuram. Over to Dr. Bibin Matthew, the organizing secretary of this year's conference. Welcome once again, ladies and gentlemen.
Good morning, one and all. So we will start the session at sharp 8:30. We will have a packed scientific program, so we will try to keep the time. So a warm welcome to all. I will hand over the session to Dr. Arunkumar. Dr. Arun, please come.
Dr. Arunkumar on. So we'll have a buzzer just 1 minute before the session is over and once again after the session. Over to you, sir.
Good morning, respected teachers, my dear friends. Yes, I'll wait for 2 more minutes as suggested by Dr. Bibin. And let us actually congratulate the entire team Kottayam for the excellent pre-operative live workshop today. 25 cases, 4 theaters, huge teamwork, amazing experience, amazing. Congratulations. Let me say once again thanks to the team Kottayam, especially the vibrant secretary Bibin and the entire ASI for giving me this opportunity to face the first ball in this innings. And let's go into the rules. See, there is a confusion. This is just an open quiz. This is an early bird quiz. Has no relation with the postgraduate quiz which will be happening in the evening. This is totally separate. There are 20 spotters, 30 to 60 seconds each, and answers to be written. I hope everyone has received your answer sheets. And 2 marks for each complete correct answer. Complete correct means you need to mention the side, you mention the scientist's name, everything. Nothing is taken as granted. A complete name, description is what is required. 1+1 if any sub-questions. Most of them do have sub-questions. No negative marking. And once the 20 questions are answered and you have written, we will collect the answer sheets. And immediately all the 20 questions will be open after collecting the answer sheets. And those who are doing MBBS or MS or DNB general surgery students will be having separate prices, and anybody who has passed MS or DNB in general surgery will be considered as consultant. So 2 categories prices, 3 prices each, first, second and third. Please write your name, institution, city and mobile number in the answer sheets. Name, institution, city and mobile number, and just put a tick mark whether you are still a PG student in general surgery or you have passed the MS or DNB in general surgery. And Quizmaster's decision will be final. There can be, without controversy, there won't be any issue. So are we ready? The first question, names of these 2 items. So A, you write the name, B, you write the name. Any surgeon to tackle an emergency, this is very, very important. No discussion between, please, no discussion. American Tourister bag, then backpack, 3 attractive prices. Please, you should not go in vain. So these 2, any surgeon, any trauma surgeon, these 2 items, just the names. A and B. Second question, closely watch this video and identify the problem, 1 mark, and probable cause, 2nd mark. Everyone knows this is a very commonly done surgery. laparoscopic cholecystectomy. Closely watch the video, and towards the end of the video, there is a problem. And just describe the problem, and what could be this is the problem, and what could be the probable cause. So I just play the video once more. No discussion, please. This is a small clip showing a laparoscopic cholecystectomy, and there is a problem. Identify the problem and the probable cause. So this is known as mindfulness during surgery. Even if it is your 1000th lap chole, doesn't matter. You need to be mindful. The entire team has to be mindful during every step of our surgeries. We cannot be casual. Just a simple lap chole, that is not even acute cholecystectomy. Question number 3. Question number 3. This is a drain bag, 4th post-op day after a laparoscopic anti-resection. Just diagnosis or even description is enough. I think there will be 2 marks. One is just description, and second is what could be the probable cause. Thanks to mobile phones, because every clinical problem, we will be able to take a pic immediately. I never had this pleasure during my MS days. So that should be fine. Question number 4, identify this fruit. I think it's common in Kerala and its medical relevance. Probably its importance has been revealed by a combined research from a US center as well as a Trivandrum center. This much clue I can give. No Googling, no discussion over phone. Deepak George, phone kardana. I know it's a personal call. So identify this fruit and its medical relevance. My wife's home garden. It's important for us. Next one, finding and diagnosis. I said quiz is 1/3. 1/3 is so easy, 1/3 is medium, and 1/3 will be difficult. Which I expect you to answer, but most of you will answer, I know that. Even the last 1/3 will be answered. Just findings and diagnosis. Because I'll give you a clue, any acute abdomen, CT is reasonably commonly used. So just finding, what is this finding? There are 3 findings, I would say, 3 or 4 findings. And what could be the diagnosis? Because it's a difficult one, I'll play the video once again. Because I want more people to answer. Absolutely, there is no issue. Next question, identify the instrument, the complete name. This is a favorite instrument in one of the teaching centers in Kerala. And Dr. Matthew Koshi used to highlight this instrument. Professor Matthew Koshi, head of the department in GI surgery and MCH Trivandrum, used to highlight this instrument. Because this, along with some other instrument, has to be there in any, intra-abdominal surgery, open surgery. So that should be fine. Closely watch this video. Identify the sign and the probable cause in this case. 1 + 1 2 marks. Again, the current generation is so lucky and happy, they don't need to see all clinical cases for learning clinical science. Everything is available on your fingertip, on your mobile. I think that's an easy one. So the question is not about the picture, but there are 2 questions. After a successful surgical resection of a colorectal cancer, an increased CEA concentration should return to normal within. That means you have done resection for a colon cancer or rectal cancer. When to repeat the CEA next? It should be clean in mind. Not too early, not too late. So that means it implies a second question, circulatory half-life of CEA. 1 plus 1, 2 marks. No Googling, no discussion, please. It's important. When to repeat a CE after a colon cancer resection, oracle cancer resection. Next question. There are many hernias described. I am just asking names of A and B. This hernia and this hernia. There are two named hernias after scientists, A and B. Beautiful illustrations. From one picture, we know around 6 hernias. So A and B. Next is a very common question. What percent of perianal abscesses eventually develop a fistula in ano later? Because especially in private sector, if you drain a perianal abscess, %% will come back with a fistula after 2 months, after 3 months, after 4 months. What is that percentage? Roughly. Because sometimes in Kerala, they will, Doctor Appa onnum mindilla, annu parnilla, veendum. So this figure, I think we can casually mention with every patient and family, this rough percentage we should be knowing. Question number 11, the difference between these two items and their relevance. We always look at the anesthesia, yes sir, but you should also look at the monitor and there are some drugs there. A and B. Because surgeons will be commonly using one item. This is again clue. Even if you are getting the clue and writing the answer, my job is done. The other one, anesthesia people are using. And most of the time, they will say, don't take that. Yours is this. And what's the basic difference between these two? I think you need some time to write this. Next one, diagnosis. A clinical picture, an X-ray, a histopathology slide, and a microbiology slide. Write the diagnosis, please. Question number 12. Just a word of caution, if you don't know the answer of a particular question and you write the next question, that should be against that particular number. For example, number 30, here it is number 12. Okay? 13, this curve is known as, because all postgraduates, whether it is MS surgery, DNP surgery, we have to submit theses, we have to do some surgeries, just nothing hi-fi, but this curve is commonly known as what? So definitely this is a cancer and a survival is plotted here. Question number 14, diagnosis. On one side you have a CT, on the other side you have something like a cytology. Diagnosis. Whenever you write the diagnosis, it should be a complete diagnosis. Question number 15. Again, this is a CT video, but I'm giving you the diagnosis. There's a case of intestinal obstruction, but there is a problem. There is an issue here. Maybe a subtle one, but just highlight the issue. Any surgeon attending acute abdomen emergencies, we should know. We don't need to wait for the radiology PG or radiology duty MO to come over. There's a problem here, there's an issue here. Question number 16. This actually I copied from an illustration in a scientific publication. Just go, these are all olden times illustrations, handwritten. and who did this, and it is about what? I still remember Dayananda sir highlighting this in one particular clinical class. I still remember, but that time I did not go through this literature. These illustrations, just about what and who did. 1 plus 1, 2 marks. Question number 17. This is a still picture of a CT. Again, the question is about what is the timing of a contrast enhanced CT scan in a case of severe acute pancreatitis. That we should know. And that should be written completely. And secondly, now focus on this case and what could be the possible etiology of pancreatitis in this case. And question number 18, you need to correlate all the 4 pictures for the same patient. There is a problem, and for this a remedy is being done. And this is a CM picture of the remedy, and this is what the surgeon told the endoscopist. And actually that was the problem. So what is the problem, and what was the remedy done in this case? I know it's a bit tricky, but occasionally we may have some problem, so we need to be with the endoscopist in the theater, in the radiology suite and all that. So what is the problem? And basically if there is a tie-up between 2 first prizes, the person who is clearly writing this answer will definitely have the upper edge, a complete answer. Question number 19. Diagnosis. This question has a dedication. I'll open up during discussion. Question number 19, diagnosis. And the last question, this cannot be Googled. Just see this CT abdomen. If someone can say, see a hornbill here, that's excellent. But if someone can answer this question, what is the bill of this hornbill? Which structure? This is a normal CT. And then that will be excellent. So 2 marks for this thing. This is a CT scan. And we can see a bird sitting there, sitting at the adrenal, sitting over the adrenal. But what is this bill, the beak, whatever? This portion, it's a normal structure. Not always seen. This is because of some other reason. What is this bill? Formed by which structure? Which normal structure? So that finishes. Volunteers, please collect all the answer sheets right now. Volunteers, please collect. Someone please, Vimal, Murali, Deepak, please help me out. In 2 minutes, please. In 2 minutes. In 2 minutes, please. Please. We don't have time. All the questions will be opened right now with discussion. And volunteers are you? Anybody from the volunteers? Now all the questions will be open. See, those who have not written name and number, it's okay. That's the first thing, very important about any quiz. Now there is no point in discussing that. Before I open up, Ranjit sir, we have All the answer sheets with us? Yes, everyone. Now, Ranjan sir will be having a bunch of chocolates here. Bunch of chocolates, 20 chocolates. Whoever in the audience opens loud and clear first time will get a chocolate right now. So shall we go to the first? Are you ready? This is just a discussion to learn 20 clinical points in our life. Just nothing else. 20. Yeah, sir, you are the authority. Please keep it with you with the chocolates also. So what is this? Goodell's airway. The A is Goodell's oropharyngeal airway. B is nasopharyngeal airway. So the green shirt. Thank you so much. And Goodell's oropharyngeal and nasopharyngeal airway. These two should be. What is the problem here? There is an intraoperative capnothorax right side. That is by the GB pushing left lateral port. This is a paradoxical movement of diaphragm. And we are identifying a hole there and which we are stitching it up. So paradoxical movement of diaphragm during any laparoscopy procedure. Anybody? No. Someone was saying diaphragm injury. Who? Come on here, we can't give you all the chocolates, but again, you owe it. So paradoxical movement of diaphragm during any laparoscopic surgery, even open surgery. Think about a pneumothorax in open surgery, capnothorax in laparoscopic surgery. And this gallbladder was so redundant, the frontal traction went up to diaphragm and it poked a thin diaphragm. Only thing is when the patient develops a bradycardia, this thing, or respiratory arrest in the posture, we should be knowing this. What is this? Fecal and, who said fecal and drain? This fellow, fecal and drain. So what could be the two causes? Anastomotic leak or proximal conduit necrosis, whatever. That's the most common thing. Nothing else. What is this? No beriberi, no cranberry. What is this? Very important. Anybody treating liver tumors? Very common in our parambu. And it's an edible fruit. This is manatakali. In our, Trivandrum, it is manitakali. Black nightshade or Solanum nigrum. There is a compound extracted which is definitely effective against HCC, liver tumor. What are the findings? A bit tough. At least findings, anyone? It's not pneumobilia, extensive air. Air where? It's an air in the portal vein. Anybody who has written air in the portal vein? Portal pyemia. So Murali will get the chocolate right now. Just see, some acute abdomens are like this. Just air in the portal vein, extensive air in the portal vein, and there is emphysematous gastritis, intramural air within the stomach. Acute emphysematous, very rare, but air in the portal vein is this ominous sign, but this patient survived. So air intramural in the posterior gastric wall and air in the left gastric vein, even acute emphysematous gastritis. What is this? This fellow, I think he is going to grab more. Schwanesi. See, basically this is a type of right angle. It is different from mixture. This angle is excellent. The striations are horizontal. So I don't know how to, and this along with Debeke. Debeke is our RC vascular sir is here. These two are very common dissecting tools in any GS surgery, especially around the vessel. Even if you dissect the bile duct, hepatic artery, portal vein. So this combo has to be in any surgery unit, definitely. So these are very important to identify these instruments. What is this? Very simple. Anybody who is dealing with thyroid, the authority is here. Babu sir is here. Chostek sign and post-thyroidemic hypocalcemia. What was the clue? There was a post-thyroidemic scar. So what is the half-life of CEA? 1 week. So so half-life of CEA is 1 week. After resection, when we should do repeat CEA? 4 to 6 weeks. Murli gets a prize also, 4 to 6 weeks. Adinu mumbe repeat edittu karyamilla. Chocolate there also, please. Bipin will get you. So these are two hernias. First is appendix, second is Meckel's. Okay, thank you so much. And there are 50 or even 100 named hernias, very difficult, but some of them we should be. And what percent of perineal abscess? Definitely in private sector, if you drain a perianal abscess, they will come back with a fistula. Dash percent. First go, first go, you say that this roughly 40%. I don't know why. 40, this black shirt. Vimal, look at the boys also. What is the difference between these two items? Madam, you are there. Thank you so much for making my day. So this is, everyone says Silocard, Loxicard. This is given intravenously for arrhythmias. What's the difference? This is given for both are 2%. This is given for infiltrations, for surgeon. This is for anesthetist. Difference? He gets it. Preservative. What's a preservative? Paraben, methyl paraben. Super. So this is a bit costly, doesn't contain preservative. Simple. Don't look at all these, but look at these. Tuberculosis mastitis, madam will get one more chocolate. I'm not seeing those who are in the back. So this is a very common stuff in almost all the quizzes. Seal-Nielsen staining. And this is a typical, and diagnosis should be tuberculosis of left breast. Tuberculosis means 1 mark, left breast means 2 marks. Again, courtesy to Babu sir, the diagnosis has to be complete. What is this? Anybody other than Murali? Kaplan-Meier survival curve. Just a name. Anybody who is doing research thesis, Kaplan-Meier survival curve. What is this? Anybody other than Murali? He is getting maximum chocolates. Our gentleman, young dancer, there. Yes. He gets his hydatid cyst. What is this? So any suspected cyst fluid, we should be sending cytology immediately to the pathology. Scoliosis, an excellent pathologist will demonstrate scoliosis. What is the issue here? I think the chocolate man will get it. Coiled Ryle's tube. Sir, industrial obstruction aanu. Ryle's tube ittu. Onnum varunilla. Never say that. Never ever say that. Don't ring your chief, unit chief and say that, sir, onnum varunilla. See, again, the insertion of Ryle's tube, nasogastric tube in an emergency, one of the side holes will commonly get folded. And don't say that, sir, your diagnosis is wrong. There is no intestinal obstruction. Onnum varunilla. So this is, see, after some time, so just see, this is a coiled Ryle's tube within the esophagus. It's not reaching the distended stomach. And this is not the oral negative contrast. This is actually intestinal obstruction. What is this? I think Babu sir gets it. Again, it's his question only. Sheshachalam Sartri. It's an Indian. He's an anatomist from Mysore, Government Medical College, Mysore. It's an Indian. So occasionally, we are very proud of all this literature, definitely. Accessory appendicular artery. There are 3 types. What's the timing of CT scan? Who said 70, young girl? Madam. Who said 72? 72, yeah. That gentleman gets it. So minimum 72 to 96 hours. After the onset of pain, it's not the reception of this patient into your ER. No. From the onset of pain, what's the science behind this? Maximum necrosis would have occurred within 72 to 96 hours. Very less likely that the further necrosis will progress after 96 hours. So whatever pancreatic and peripancreatic tissue damage has to happen, it will happen within 96 hours. So an early CT will underestimate the future necrosis. That's it. But you can do an early CT when there is a diagnostic dilemma. And the possible etiology in this case, gallbladder. Gallbladder is filled with stone and there is pericholecystic edema. What is this? ERCP. Ajumar sir gets the chocolate. ERCP is good enough. Yes, intraoperative laparoscopic cholecystectomy, bile leak. And bile leak is from where? sir gets one more chocolate, Ajay sir gets one more chocolate. So it is an aberrant right sacral duct lateral injury. Aberrant right. And what is this? Uyyo, superb, right-sided cervical rim. Basically, this is our teacher who says, if you see a chest X-ray, you don't see anything, just, this is an UG teaching. In your exams, in a chest X-ray, a very famous teaching by our own Fasil sir. So, cervical rib right side. And what is this? Who said splenic vein? I think he will get it. That's a splenic vein. See, the beauty is, this is splenic vein, superior mesenteric vein, main portal vein, right posterior portal vein, right portal vein and right posterior portal vein. Just imagine, splenic vein is below and right posterior portal vein is above. But whenever there is an elevation of left hemidiaphragm, the entire vascular axis will shift towards cranially and all these vascular structures will be in the same. This is just an anatomical curiosity observation. That's all. I think thank you so much. Thank you so much for the wonderful active participation.
Thank you so much, sir. Congratulations to Dr. Arunkumar. That is quite lively, I expect.